Hi, everybody. Welcome to today's webinar. My name is Karen Bischoff. I am the founder of the COVID-19 Long Hauler Advocacy Project. Today, we're going to be speaking with Lauren Stiles, Research Assistant Professor of Neurology at Stony Brook University Renaissance School of Medicine, co-founder and CEO of Dysautonomia International. Lauren.
Thank you, Karen. And I just want to give a shout out to Karen for all the great advocacy work she's been doing, and everybody at the Long COVID Alliance, Solve ME/CFS, Body Politic. This is an incredible group of organizations that have come together to build the Long COVID Alliance. And I look forward to even more people joining us because we have to transform our understanding of post-viral illnesses. I have a normal slide lecture I do on POTS. That's a good 45-minute lecture for 15-minute Q&A, but I was speaking with Karen and some other long COVID patients who wanted specific things. So it's a little longer than that. I'll go fast. I'm gonna give everyone the slides afterwards. I'll give it to the Alliance to post on the website. So if I go too fast, don't worry, I'm just covering like as much as I can in the window of time. So a little background on me. I have an unusual background. As you can see, I'm a JD, which is a lawyer. I am first and foremost a dysautonomia patient I'm a lawyer who became an accidental neurology professor. That doesn't happen every day, but I've had dysautonomia for 10 years. I'm doing pretty well now, and I'm working to do as much research as possible to try to understand autonomic disorders, including the autonomic dysfunction that we're seeing in some long COVID patients. So what is long COVID? Let's sort of get on the same page on the terms here. So I am not being really precise in how I'm using this term because I think it's still being defined, whether it's, have you been sick for a month? Have you been sick for 3 months, 6 months? What should we call it? Is it long COVID, long haul, post-acute sequela of SARS-CoV-2? You know, there's all these names for it. And so let's just say, for the sake of this discussion, we're using this term kind of loosely to mean people who have had COVID and are having long-lasting symptoms that last much longer than the typical viral infection. So what are the things that cause symptoms to last for a long time after an infection, just as a general concept, not even in COVID, but in other viruses? So you could have potentially an ongoing infection or even like a latent kind of hidden infection hiding out in maybe your nervous system tissues. You could have a secondary infection. Perhaps you had an initial virus and then you developed like a bacterial pneumonia. You could have an infection that resolved, but you have some residual tissue damage like lung or cardiac or brain damage. You could have an infection that resolved and you have an ongoing immunological response like an inflammatory disorder or an autoimmune condition. You could have developed deconditioning when you had the acute viral infection. You can have things we haven't figured out yet. And I always say that because I think we have to be humble in trying to understand very complex diseases that are different in everyone. And then a combination of above is probably what most people have. A little bit of deconditioning, a little bit of tissue damage, a little bit of ongoing immunological response. You know, it's probably a combination. And this question is what's going to be answered with a lot of amazing research that's going to happen on long COVID. As many of you know, the Long COVID Alliance and all of the sister organizations advocated for Congress to fund over $1 billion in long COVID research, which was passed by Congress, and the first grant applications were just submitted on this. So I think we're going to have a lot more answers after that research starts happening to help us understand what's happening. And it might be different in different people. So what is dysautonomia? It's not a specific diagnosis. It's a general term that means dysfunction of the autonomic nervous system and includes all the different types of dysautonomia. Sort of like cancer includes many different types of cancer. So autonomic nervous system problems can be caused by structural problems like damage to the autonomic nerves. They're actually missing or they're damaged enough that they don't work properly, or they can be functional. And so some people hear that word and they kind of cringe. It's like a not good, not nice word in medicine to sort of, it's used to sort of say to patients, it's all in your head. But in the true sense, a functional nerve disorder is when your nerves are intact, but they're not working properly. And that could be due to antibodies, that could be due to catecholamine, neurotransmitter problems. And in many people, whether you have primarily a structural or functional problem, you usually end up with both. So it's not a clear-cut thing usually. So just a brief, it seems like a complicated chart, but it's actually a simplified version of what your autonomic nervous system regulates in your body. All of your organs that when they communicate with your brain, they're communicating mostly through the autonomic nervous system. So your heart rate, your digestion, your blood pressure, all of your stuff that happens automatically that you don't have to think about is regulated by your autonomic nervous system, including your immune system. And this is very important to post-viral syndromes because obviously at the initial onset of your infection, you had an immune system problem. And sometimes the autonomic nervous system can sort of perpetuate that immune system staying kind of in a cranked up, fighting off a virus that may or may not be there anymore. So how do we recognize autonomic dysfunction, or what's also called dysautonomia? It's really important to look at the whole patient, because that autonomic nervous system, usually when it goes wrong, it doesn't just go wrong in one organ, it sort of affects the whole autonomic nervous system more commonly. So patients can have orthostatic intolerance, which is difficulty with standing upright. They have symptoms like low blood pressure, or they feel lightheaded, like they might faint, or sometimes they actually do faint. GI dysmotility, too fast or too slow. Pupil dysfunction, which can come with light sensitivity and headaches from like bright sunlight, or sort of difficulties focusing and reading if your pupils are not constricting normally, because your pupil constriction is controlled. All of this is controlled by the autonomic nervous system. Bladder dysfunction, abnormal sweating, dry eyes and dry mouth. Again, that's tears and salivation is controlled by the autonomic nervous system. Temperature sensitivity, like changing in temperature from going in from a warm place to a cold place, can be like almost really jarring to the body. Flushing, especially upper body flushing, like chest and up. And in males, erectile dysfunction. So you don't have to have all of these symptoms to have an autonomic problem, but it's important to consider the big picture. So these little scales of justice. Your body, your autonomic nervous system wants to be in balance. Your parasympathetic and your sympathetic are doing sort of, the parasympathetic is like the rest and digest of the nervous system to help you sort of relax and feel calm and sleep. And the sympathetic nervous system is sort of what helps you when you're cranked up and you have to give a big lecture, or you have to run a marathon, or, it's the part of the nervous system that's the get up and go. And it gives you lots of symptoms when it gets overly activated, which is what a lot of post-viral dysautonomia is. So do long COVID patients have dysautonomia? The research is still going on this, right? It's still so new. Doesn't feel new to those of you who've been living with it for a year or maybe more recently developed it. But these are just some of the case reports that have come out from Harvard, Stanford, Karolinska Institute in Sweden. Some of the UK universities have put out papers, SUNY Buffalo in New York. So these are, really respected autonomic labs who are saying, yes, we are seeing this in some of our patients coming through. So I got involved in some long COVID research pretty early because I had COVID at the beginning in like February of 2020. I live in New York and I was traveling, and I think I just, unfortunately picked it up pretty early. And so I joined these COVID groups, and I noticed that patients were talking about dysautonomia symptoms right away. I was like, wow, this sounds a whole lot like the dysautonomia that I study. So I contacted some colleagues, and Mitch Miglis at Stanford University's Autonomic Lab, the two of us put together a long COVID survey. And this is just one of the data pieces from that survey. We have like at least 3 papers in progress right now. They're in various stages of publication. But so what I wanted to show you is this sort of kind of big picture data. So COMPASS stands for Composite Autonomic Symptom Scale. And it's 31 questions in a survey that patients can fill out on their own. And it's developed by Mayo Clinic and helps assess the severity of someone's autonomic nervous system problem. So Mayo actually hasn't published what normative data is, like what healthy controls would have, but there have been some publications from other universities. And so generally speaking, if your COMPASS score is 0 to 19, you have either no autonomic dysfunction or maybe a little bit of mild autonomic dysfunction. That's generally the normal range. And then 20 to 39, 20 to 40 is sort of a moderate autonomic dysfunction. Something like POTS would be in the 20 to 30 range often, 20 to 40 range, sorry. And then 40 and above, you start to get into the more severe autonomic dysfunction. So COMPASS scores are, since they're a survey, it's not definitively telling us it's the autonomic nervous system causing this, but it's a big, big hint that it probably is. And so then we need clinical studies where we study the patients in person to actually measure their autonomic nervous system activity. And that's going on at Stanford and many other centers right now. So what forms of dysautonomia? Since dysautonomia itself isn't a diagnosis, you really want a doctor to pinpoint what type of dysautonomia they think you're having if you're experiencing dysautonomia symptoms. And so orthostatic intolerance, which is fairly common, is showing up. POTS is showing up, and that seems to be the most common type we're seeing in the long COVID patients, at least the ones that are coming to autonomic clinics. So if people have a milder autonomic problem, they probably aren't going to get to referred to the autonomic clinic at Harvard or Stanford or something like that. Autonomic failure, which is pretty rare in the general public, also seems to be very rarely showing up in a few COVID patients. And these things are known to happen. All of these conditions are known to happen after viruses and other infections. And then I put GI dysmotility. It seems to be common on the symptom survey questions, and it can be autonomically driven, could be caused by an autonomic problem. It could also be caused by other stuff. You could have an acute infection of your GI tract. You could have, small intestinal bacterial overgrowth. It may not be an autonomic problem, but that is one manifestation that could be autonomic. So I'm not going to go into detail on this, but I did want to throw it in the slides because we often get a lot of questions about how do doctors distinguish between the different types of dysautonomia? Because at first glance, they all seem pretty much the same. But there are reasons for the diagnostic criteria. There are different mechanisms involved in these conditions. But I like to think of them as a range of severity. And even if you have the mildest one, it can feel completely debilitating. So I don't want anyone to feel like invalidated if I see it's a less severe autonomic impairment, because I know people who are bedridden with the less severe type. But it's important to understand, like, some of them are associated with neuropathy and some of them aren't. So I'm not going to go into detail for the sake of time, but I wanted to put this in the slides. So what is POTS? POTS is a chronic autonomic nervous system disorder, but it's mostly associated, everyone knows it as a tachycardia problem, but it's actually the entire autonomic nervous system that can be impaired in POTS. It comes with a really wide range of severity. I have POTS friends who are bedridden on feeding tubes with bladder catheters, and I have other POTS friends who are literally right now climbing Mount Kilimanjaro. And that friend who is climbing Kilimanjaro was a bedridden POTS patient at one point. So there's this big spectrum of severity. And so one person's POTS story is not necessarily the same as someone else's. It's the most common diagnosis seen in the autonomic clinics. Before COVID, it was estimated to impact 1 to 3 million Americans. We don't know how many more we're going to have, but it certainly seems like there's been a growth in the number of POTS and other dysautonomia patients because of COVID. POTS is about 90% female and Caucasian, but we're very aware that due to lack of access and disparities and racism in healthcare, there probably are other higher percentage of people who are not Caucasian that have it that just aren't getting diagnosed due to major problems in the healthcare system. So just be aware of that. The peak age of onset of POTS is age 14, just kind of the end of puberty, especially for girls. And but it's not just a teenage condition. Half of patients develop POTS in adulthood. So sometimes you'll see media reports calling it a teenage girl's disease or something. It's not. It can affect males. It can affect anyone. 50% of POTS patients have a post-viral onset, and that was before COVID. So maybe that percentage changes a little now that we have so many new COVID patients. But it's a common concept. It's a common phenomenon to develop POTS after, and it's not any one viral infection. It's pretty much any infectious agent. We also see POTS get triggered by concussions, by pregnancy, by car accidents, and other things. These are all things that stimulate the autonomic nervous system and the immune system in a bad way. And a subset of people just don't bounce back from that. So here are the POTS diagnostic criteria. They're a little kind of boring to read through, but you have to have a heart rate increase of 30 beats per minute or more from the laying down position to the standing up position. Usually we want to diagnose POTS with a tilt table test, but if that's not available, we don't want to deny the patient the ability to get diagnosed. So you can do orthostatic vitals like at the bedside with the doctor, but a tilt would probably be a little more precise because there's other equipment that usually comes with the tilt testing. So for adolescents, the criteria requires 40 BPM or more heart rate increase because kids naturally have a higher heart rate spike when they stand up. Younger than age 12, it's very rare to have POTS before puberty. And there is no agreed upon diagnostic criteria for it because it is so rare. So doctors just kind of eyeball it and say, does this seem like it's fitting the POTS picture in the younger kids? It has to be in the absence of orthostatic hypotension. So this causes a lot of controversy on the support groups, but it's the agreed upon international consensus criteria. All the cardiology and neurology societies agree with this. And it's not to say that you can't have orthostatic hypotension, you can, but if you have orthostatic hypotension, that's your diagnosis, not POTS. And orthostatic hypotension itself has its own criteria. So you want to have symptoms with POTS. It's not just about a heart rate increase. There has to be orthostatic intolerance symptoms. And the criteria used to be 6 months, but it's more recently being changed to 3 months, recognizing that most people who are sick at 3 months are still going to have it at 6 months. so that's unfortunate if you're going through that right now. But the importance is you don't want to diagnose someone who just got tachycardia yesterday or last week with POTS, because it's very likely that it's going to resolve. And there's just a subset of people that it's going to keep lasting. The POTS symptoms tend to get worse with standing and improve with laying down, but that doesn't mean POTS patients have no symptoms laying down. They have plenty of symptoms when they're laying down. And the doctor should rule out other overt causes of orthostatic symptoms and tachycardia. So that's a pretty long list. It can include things like anemia, dehydration, recent blood loss from a major surgery or a car accident, things like carcinoid, neuroendocrine cancers, which some patients have been misdiagnosed with when they end up finding out that they have POTS. And thyroid disorders is another thing that can cause a lot of tachycardia. So you want to make sure that it isn't an identifiable underlying condition. So POTS symptoms is a very, very long list. And I'm sure as you're reading this, it looks an awful lot like a list of long COVID symptoms and also like a list of ME/CFS symptoms. So all of these conditions, I call it the syndrome soup. There are a lot of these idiopathic syndromes where we don't fully understand what causes them, but they tend to have a very long list of symptoms that are, at least in the POTS context, most of these symptoms can be attributed to autonomic nervous system dysfunction. So I'm not going to leave up the long symptom list because I'll give you the slides and I want to just keep going through this. So purple POTS legs. Sometimes people say POTS is an invisible illness, but I actually say it's not invisible if you know where to look. About half of POTS patients have these sort of purplish POTS legs, and people of different races and ethnicities can get this too, although sometimes it's not as easy to see. But it is due to a blood pooling problem. And you can notice also if you have this sort of purple blotchy legs and you press on your shin, sometimes you have a delayed refill of your capillaries. It kind of stays blanched for a little while. It's harmless, but it is not everybody's favorite look with summer shorts on. So coat hanger pain. This can be caused by the large muscles of the upper back not getting enough good blood flow. POTS is really a problem of blood flow. We have not enough blood and it's not getting to the right places. It's not getting to the upper part of the body as much as you want it to. So your muscles get like a lactic acid kind of fatigue faster than if they had been getting good blood flow. So how is POTS diagnosed? Really, really important for the doctor to take a detailed personal and family health history. About 20% of people with POTS have a family member with POTS or a similar autonomic problem, but not everyone. There's some people, it just seems to be they're the first in the family to get lucky with that diagnosis. Again, I mentioned you want to do it with a tilt test, but bedside orthostatic vitals are acceptable. And depending on where you go, you'll get a very different workup. And this is something Dysautonomia International is trying to address. We're trying to get evidence-based medicine to help us guide what the proper workup should be. But for now, these are some things you might get at different places: an EKG and echo to make sure your heart is structurally and okay, and then it's not an arrhythmia. And that's probably extra important in COVID patients, since we know that COVID is causing some people to develop myocarditis and other structural cardiac issues. Valsalva maneuver and heart rate response to deep breathing are tests that are done in autonomic labs, which there's only a few of in the whole US and a few of outside of the US. QSART is something I'll talk about on a future slide. Intraepidermal nerve fiber density skin biopsy and sweat gland nerve fiber density skin biopsy. This can measure the density of your small fiber nerves. And this is important in POTS because more than half of POTS patients have a small fiber neuropathy. So I've been talking to different autonomic labs that do this to see if they're finding this in their long COVID patients. And it doesn't seem to be as common in the long COVID POTS patients as other POTS patients, but we don't know if that's because they just got POTS within the last 6 months to a year. We don't know in POTS how the illness evolves over time because we haven't done good longitudinal research yet. So this is something to be aware of and keep an eye on in the research and in your own discussions with your doctors. POTS patients tend to have elevated plasma catecholamines. These are the neurotransmitters that regulate your sympathetic nervous system. They have elevated norepinephrine quite often in their blood. GI motility testing can be used, all sorts of different ways to see if the GI tract is moving properly. And then blood tests, which is a pretty generic statement. There's a zillion blood tests that doctors might do depending on the particular presentation of the patient. Things to look out for in POTS would be low vitamin D is really common, B12 deficiency, which can cause a small fiber neuropathy or even a large fiber neuropathy. And looking at iron storage and iron and ferritin and stuff like that, because POTS patients tend to have an iron storage deficiency in a subset of patients. So this is just a photo of someone getting a tilt test. She's smiling, so she must be one of the healthy controls getting the test. But when a healthy person gets put on a tilt table, their heart rate just goes up a little bit and their blood pressure stays pretty normal. And then this is the tilt table down here getting tilted up and then someone being tilted back down to laying down. And so you can see their heart rate and blood pressure stay pretty much in range. A POTS patient, their heart rate just keeps going up and up and up and up. And this is where the tilt table got put back down. Their blood pressure stays mostly normal, but you can see it looks very different than the control. And it's sort of a more labile blood pressure bouncing up and down. A third of POTS patients have a slight drop in blood pressure on standing. A third remain normotensive, and a third will get an elevation in blood pressure when they stand up. And unfortunately, a lot of doctors will say, oh, your blood pressure didn't drop, you don't have POTS. So if your blood pressure drops, that has nothing to do with a POTS diagnosis unless it drops so much that you have orthostatic hypotension, in which case you don't have POTS. So a lot of doctors are not well informed on how to diagnose POTS. So we get a lot of patients who are misdiagnosed, which can be very frustrating for the patient. So if you read up on POTS, you might read about subtypes, and these are not distinct diagnoses. These are just different characteristics that we find in different POTS patients. Most POTS patients have more than one of these or even all of them. More than half of POTS patients have small fiber neuropathy, neuropathic POTS. About 70% of POTS patients are hypovolemic, meaning they have low blood volume. Majority of POTS patients are hyperadrenergic, meaning they have elevated plasma norepinephrine levels. And a majority of POTS patients have autoimmune antibodies that are impacting their autonomic nervous system. So everybody's got varying degrees of all of this. Small fiber neuropathy, this is just a cool slide from an image from Harvard's autonomic lab. Dr. Roy Freeman sent me this. And so we know that POTS patients have pseudomotor neuropathy, which is the small fiber nerves that control the sweat glands. These are autonomic small fibers. There's also sensory small fibers, and we have an increasing amount of research showing that POTS patients have a sensory small fiber neuropathy too. Not everyone, but a majority of patients. This is my not so attractive looking leg. As you can see, I have purple POTS toes in this photo. And I did have some bluish sparkly toenail polish on. So thankfully my toenails aren't actually that color, but my foot is looking kind of purple. This is a QSART test done in an autonomic lab. It's a non-invasive test that measures the function of your small fiber sweat gland nerves. And so it's sort of like a barometer of something else is going on in your autonomic nervous system if this test is abnormal. And a little bit more than half of POTS patients will have abnormal QSART as I did. This is just some data on sensory neuropathy, small fiber neuropathy and POTS symptom reporting. A large majority of POTS patients report burning, numbness, and tingling. If you have burning, numbness, and tingling, you might have a sensory small fiber neuropathy. It might not be a neuropathy, but this very commonly is sort of the presentation that a sensory problem would present with. I actually did not, in the beginning, I did not feel any symptoms of a sensory neuropathy, but it turns out when I had a biopsy, I actually did have one. So it's not always obvious just from the symptoms. Here's just another study that confirmed that there was a clinical study that was done more recently, found that quantitative sensory testing, which is a non-invasive test to screen for small fiber neuropathy in the sensory domain, that it correlated with biopsies. So maybe you don't have to get a biopsy if you get QST done. This is a study, the Big POTS survey that Dysautonomia International did with Vanderbilt University and University of Calgary on over 4,000 POTS patients, and it's still enrolling. If anyone's interested, it's on our website. And we asked them many different things, but we asked them about their other diagnoses, and they have a lot of diagnoses. 84% of POTS patients have other diagnoses. Commonly things like autoimmune diseases, Ehlers-Danlos syndrome, chronic fatigue syndrome, irritable bowel. These are the syndrome soup that I sometimes refer to. It's these overlapping syndrome conditions that we desperately need more research to figure out how they're related, how they're different, and what we can do to help people with these conditions feel better. POTS and autoimmunity, that's a whole talk into itself that we have many of lectures on it on our website, but just gets one slide in this talk. POTS patients, a majority of them have elevated antibodies that modulate the autonomic nervous system in an unhelpful way. And these antibodies are potentially one of the causes of POTS, but it's still early research. So we're funding more research to better understand how these antibodies could be causing, or if we remove these antibodies, do we get rid of POTS symptoms? So Dysautonomia International actually funded a study at Stanford looking for these antibodies in long haul patients as well. So there, if anyone lives in the San Francisco area, Stanford has some great long haul COVID research going on. And we have a ton of case reports and case series on POTS patients with known autoimmune diseases. And their POTS symptoms often improve when they get immunotherapy to treat their underlying autoimmune disease. Not everyone, but a lot of them. So this gives us hope that if we can identify some biomarkers of autoimmunity in POTS, that we can develop some immunotherapies that may help. I just wanted to mention there's some new research out of Vanderbilt showing glucose dysregulation in POTS. And this is helpful to know because you can alter your diet to try to address this. So when your sympathetic nervous system is activated, as it is in POTS, your insulin level should go down and your blood sugar level should go up. And this is sort of evolutionarily to help you run away from the bear that's chasing you, like the fight or flight, right? But in POTS, we found that there's insulin resistance in POTS patients, and that their elevations in glucose actually correlated to the worsening of their orthostatic symptoms and their heart rate as well. So the recommendation, because of this study, and it actually was known by POTS patients just from our own experiences before the study, that you should eat smaller meals more often, eat lower carb, if you're going to eat carbs, try to eat complex carbs like vegetables rather than simple carbs like cakes and cookies. This is sort of obvious dietary advice for everyone. Unfortunately, sorry, Karen, I know it makes me sad too. And eat some lean protein with every meal to help you sort of modulate your glucose spikes a little bit more. And eating smaller meals more often might also help if you have GI motility problems. Instead of taking in a big meal at once, just sort of grazing throughout the day. So everybody wants to know, do people get better from this? So I don't have a great answer. I have the data that I have. So this is the big POTS survey data that I spoke about before, 4,000 POTS patients. These patients were recruited on our support groups. So the word of caution on this is, while it did show 42% improved, 44% saying they felt worse over time, and 10% said they felt about the same, the patients who recover don't hang out on support groups to take surveys, right? So this data is skewed. We would know that if we were doing a longitudinal, like a prospective study that followed patients from the day they were diagnosed until, 10, 20 years later, we think that a higher percentage of them would report recovery or improvement, but they just don't hang out on, like, if hopefully all of you listening to this somehow get better and, maybe don't have the time to be listening to webinars in the middle of the night about complex chronic illness. But so just take this with a grain of salt, which is a POTS joke. Okay, so a word of caution for COVID patients. I don't want anyone to assume that if you have all these lightheadedness type symptoms that, oh, I must have POTS or dysautonomia, because COVID, we know, can cause very serious complications that can cause similar symptoms. So myocarditis, which is inflammation of the heart muscle, pericarditis, inflammation of the lining of the heart, cardiomyopathy, pulmonary embolisms. These things can cause symptoms that look just like dysautonomia, but they're not dysautonomia. And you don't want to begin treatment for dysautonomia if you have one of these serious COVID complications. So just talk to your doctors beforehand, make sure they have ruled out anything kind of dangerous like this. And then once you have that ruled out, you can, talk to them about whether you do have a form of dysautonomia, beginning a treatment path for that. So the other thing I have to mention is it could be deconditioning. Nobody likes hearing this, especially patients. I'm a patient. I don't even like talking about it because I know people get upset at me, but I'm not saying that your whole illness is caused by deconditioning or it's your fault that you got sick or anything like that. But when you have a viral infection and you develop a post-viral syndrome, you feel awful and you probably are getting less physical activity than you did before you had COVID. And so even just one day of bed rest can reduce your cardiac function by 5%. If you add to that, maybe you had a little bit of cardiac damage or some inflammation at the same time, you can very quickly become cardiovascular deconditioned. And you can be deconditioned even if you still have six-pack abs and big arm muscles, you can still have a cardiovascular deconditioning and not see it. So the good news is if deconditioning is all or part of your post-viral problem, it's fixable, but it's really hard to fix, especially when you're dealing with an underlying, also having a real post-viral syndrome that is maybe immunological in nature. So dysautonomia and deconditioning symptoms overlap a lot. And so it's hard even for the top experts to sort out what is actual autonomic nerve problem and what is deconditioning. And they've been fighting about this in the literature for years. And I just put this together because I wanted people to understand that there's a lot of overlap here and it isn't something we should ignore, because even if you had a cure for your dysautonomia, if you're deconditioned, you still need to deal with it. So the other way to look at it is that dysautonomia itself can cause deconditioning. This is just an example of, any kind of initial trigger of your autonomic dysfunction causes reduced exercise and activity, causes deconditioning, worsens your autonomic symptoms, and it just becomes this vicious cycle that's pretty hard to break out of. And that doesn't mean that everyone, if you just exercise, you get better. I wish it was that easy, but it is not, as many people with post-viral syndromes will tell you. There's a lot of different things that you have to do, self-care kind of stuff. There's no way I can get into all the detail on treatment in the time I have left, but I just wanted to give an overview of all the non-pharma things we do for POTS and orthostatic intolerance, increasing the salt and fluids to a lot more than most people get in their everyday. Medical compression stockings and abdominal compression. I have a slide on that in a bit. Good sleep habits is really important. It's hard to get sleep. Sometimes one of the symptoms people have is like an insomnia or chronic pain that makes it hard to sleep. But if you're having sleep dysfunction, talk to a sleep specialist or maybe your neurologist about trying to do whatever you can do to improve your sleep will improve your autonomic function. We know that if you've ever pulled an all-nighter, especially when you have developed a chronic illness, the next day you will feel so much worse, more tachycardia and, you know, more lightheaded and everything. Managing stress, healthy diet, and healthy diet means something different to everyone, but try to find what works for you. A lot of POTS and dysautonomia patients find low carb, trying keto or paleo or things like that aren't carb heavy diets seem to help. Cooling vests in the summer and the warmer months can help you tolerate warm weather a little bit longer. Avoiding things that trigger your symptoms, which might be heat or prolonged standing. Hot showers is a trigger for a lot of people. So sometimes taking a shower right before bed, if you're going to feel lightheaded and tired after a shower, use it to your advantage, take a shower right before bed, and then get lightheaded and dizzy and fall asleep. So alcohol, I hate to be the party pooper, but alcohol can worsen neuropathies and can dilate blood vessels. And this can make dysautonomia patients feel a lot worse. Although some people with POTS do fine with alcohol. And then listen to your body. That's probably the most important thing. You're the one that lives with this, and over time, you'll gain an understanding of what's going on with you and what makes you feel better, what makes you feel worse, and try to pay attention to that. So if you are of my age, you might recognize these guys. So I say that POTS exercise therapy has to be like the Beastie Boys, which is one of my favorite songs, Slow and Low. It was on License to Ill in the 80s. And so slow and low, what does that mean? So when you're doing exercise, you want to start really, really slow. Don't think of exercise as I got to run on a treadmill. That is way too much, way too fast, and too much for some people, even at all. Start with reclined exercises like floor-based yoga mat type activities, recumbent rowing, recumbent biking. If you are not a fainter, swimming, maybe you need a buddy to be with you or even a physical therapist. And these reclined exercises help you get movement and blood flow and muscle toning without challenging the orthostatic stress that you already have a problem with if you have dysautonomia or POTS. It's really, really hard to exercise when you have POTS. It feels awful. Some people get to the point where they can run 5Ks again, and some people keep trying exercise and just sort of stay in that never feeling good from it mode. And so I'd say everyone's different, and trust your instincts, trust your body, and do what you can. I'm no judgment on the exercise stuff because I've lived with this myself. Hydrate, hydrate, hydrate. That is the simplest thing to say and actually pretty hard to do when you don't feel good, or if you have nausea or GI pains. So I just put some examples of different types of things that count as hydration. Caffeine, alcohol, and sugary drinks like Coca-Cola don't count because they're actually dehydrating. So I do actually a cup of bouillon in the morning sometimes, like especially in the winter. It's a nice, instead of coffee, which makes me more tachycardic, a cup of chicken bouillon in the morning. Soy sauce on everything, V8. You find all sorts of salty snacks that help get you through the day. Compression garments. We actually have some research from from University of Calgary showing recently that in POTS patients, abdominal compression is actually more important than leg compression. Most of your blood, when you stand upright, gravity naturally pulls your blood down. And if you have an autonomic problem, you have a hard time constricting your blood vessels and pumping that blood back up. So most of your blood will actually pool in your gut, lower gut area, and your thighs. And so compression stockings come in all different shapes and colors and different styles, and you got to find what's comfortable and works with you. It works best if you put them on in the morning when you first get up, because your blood will sort of pool throughout the day and sometimes lead to some edema, especially in your legs. One slide on the many, many different medications used to treat POTS. We have whole lectures on pharmacotherapy and POTS on the Dysautonomia International website if anyone's interested. But the general concepts are we're trying to constrict blood vessels with drugs like midodrine or octreotide, which is used much less often. Sudafed PE is on here. not as a recommendation for regular standard therapy, but it's very similar to midodrine. So if you run out of your midodrine or you're on vacation, if you pick up a Sudafed PE, it has a good short-term trick, but not good for long-term use. Blood volume expansion, because POTS patients and other dysautonomia patients have low blood volume. They tend to have, POTS patients in particular tend to have low aldosterone, which is a hormone that helps regulate your salt and fluid balance in your body. So we replace aldosterone with a synthetic form of it called fludrocortisone or Florinef. And so that's a common POTS treatment. And you have to increase your salt and fluids for that to work. Desmopressin is a drug that is used sometimes, erythropoietin, which is famous for being the drug that, who is the famous biker, of course, Lance Armstrong. He took erythropoietin to help him increase his blood volume and win some races. So it's very hard to get your doctor to prescribe this, but if you tell them that you want the Lance Armstrong drug, they usually know what it means. IV saline is a really effective treatment to reduce the tachycardia in POTS and to increase blood volume, but it's very controversial in POTS world whether or not people should be getting chest ports and PICC lines for this, because we have had POTS patients die from chest port complications like blood clots and sepsis and infections and stuff. Beta blockers and ivabradine are both types of drugs that slow down the heart rate. Mestinon is a drug that increases the parasympathetic nervous system activity to kind of balance out the excessive parasympathetic tone that POTS patients have. I put immunotherapy with question marks because it's not commonly accepted as POTS treatment right now, but is something that an increasing number of patients are trying to gain access to, and there is research happening on it in POTS. So it's something to kind of be on the lookout for. Mast cell dysfunction is fairly common in POTS patients, and I know this is happening in some of the long COVID patients too. In POTS, it tends to occur in the patients who have more sympathetic nervous system activity. The more hyperadrenergic they are, the more likely their mast cells are to misbehave. And so controlling the autonomic dysfunction might actually help regulate the mast cell dysfunction a little bit too. But if that's not enough, there are over-the-counter drugs. H1 and H2 blockers would be like Zantac and Zyrtec or Benadryl, and then a list of other drugs that immunologists can work with you on.
Lauren, sorry to interrupt. 5-minute warning.
Sure. Okay. I'm talking fast. I'm sorry. I would just want to emphasize whatever the cause of if you have a post-viral dysautonomia or you have a post-viral deconditioning or some other manifestation of long COVID that is not a dysautonomia, it's not in your head. And I feel like we need to say that to each other because sometimes doctors aren't kind enough to say that to us. It's not in your head. And even if it was, it needs to be taken seriously and treated properly and not dismissed by the medical system. So these concepts of post-viral dysautonomia or post-viral deconditioning are well-known phenomenon. COVID is not the first condition that has caused a post-viral syndrome. And we know this since at least the 1800s. This has been in the medical literature. I want everybody to know you're not alone. There's millions of people around the world who live with different forms of post-viral illness. Some people fully recover, takes time. Some people improve over time, and some people don't improve. And I think it's important to be honest about that too, because a lot of doctors, they want to be your cheerleader. They want to tell you everything's going to be fine. And let's hope it is. But I think that we have to also be honest and say sometimes people don't get better and they do live with these chronic illness, these post-viral conditions for a very long time, or maybe even their whole lives. So with that, I wanted to close out with just sharing some links. This is a link to the Stanford Stony Brook University's long COVID survey. And so anyone who's over the age of 18 who has had COVID confirmed or suspected is welcome to take this survey. A couple thousand people have taken it already, and we're already cranking out journal articles from it, but we'd love more people to participate. It's also going to have follow-up surveys. So if you're willing to share your contact info, it's optional. You'll get follow-up surveys every 3 to 6 months. Tracking long COVID patients over time is going to be really, really important. So Karen, could you share that link?
Yes.
Okay, thank you.
I think we put a bunch of them in there before. If maybe Carmen wants to do them while we go over Q&A.
Sure. Here's a bunch of other links. I just wanted to throw them in the slides. I'm not expecting everybody to write these all down so quickly, but these are just different dysautonomia international resources. And I wanted to give a shout out to the Long COVID Alliance online community. Follow us on Twitter, on Facebook, on Instagram. Check out the website. It's a really awesome collaboration of many different organizations who bring different strengths to the table. And I'm so excited to be part of it and to be part of this webinar. So thank you for having me. And Karen, I'm happy to do questions if you want to.
Yes. So one of the most common questions I think that we all get is, what kind of doctor diagnoses somebody with POTS?
Yeah. So most commonly POTS patients are diagnosed by a cardiologist, but I would say any doctor can measure orthostatic vitals. So any doctor should be able to diagnose POTS. They often don't know about it. And if you go to cardiology, they're more likely to know about it, but cardiologists in general tend to do, I would say, just the very entry-level treatment. And some people with POTS have a fairly mild case. They just need salt and fluids and maybe some exercise and they'll be okay. And that's awesome, but there are some people who have a more severe, like neurological manifestation of POTS that need more detailed testing and workup for underlying conditions and different medications that cardiologists might not offer. So I would say start with your primary care if you can, talk to them about it. There's a ton of literature out there now on post-COVID POTS, so they should hopefully be open to this idea. If they don't know what to do, go to cardiology or electrophysiology. I say electrophysiology might be more likely because they often have access to tilt table testing. The doctors who do tilt table tests are almost always electrophysiologists, which are a type of cardiologist. And then also there are autonomic neurologists, but there's only a few of them in the whole country. So it's pretty hard to find one. And they all have wait lists that are like 6 months to 3 years long. So I wouldn't wait. I think it's important to get diagnosed early so that you can start treatment early. And in theory, if you're diagnosed and treated early, you might have a better long-term outcome. The average POTS patient before COVID was like misdiagnosed for like 6 years when we started tracking it. And so we're seeing COVID patients getting diagnosed like in 3 months, which is amazing. I mean, it still feels too long when it's you going through that 3-month misdiagnosis, but it's much better than it was. So we're hoping that helps people with long-term outcomes.
The next question is it common for POTS patients to have lower CO2 levels? I think I personally want to expand on this and say, can you talk about air hunger and the role it plays on people feeling short of breath and oxygen drops?
Yeah, so there really isn't much research on oxygen and blood gases in POTS. There's a little bit of research from Julian Stewart at New York Medical College on what he calls hypercapnic hyperapnea, which is a very scientific way of saying hyperventilation, but it's not an anxiety-driven hyperventilation in POTS. It's something he thinks it's something to do with the autonomic regulation of the different sensors. And your autonomic nervous system is involved in regulating all your homeostasis, and breathing is a huge part of that, right? So I don't really have details on blood gases. I would say in COVID patients in particular, if you have low oxygen issues, that's not really a POTS issue. That's probably more of a COVID thing. So I would definitely want to talk to your doctor about that if you're still getting that.
The next question, I like it. How similar is what you're seeing in long COVID patients with POTS to other post-viral triggered POTS?
It's the same. It's, I would say on the whole, it's the same. There are always, even in POTS that has nothing to do with COVID, there are always sort of nuances of people's cases, right? Like I had post-concussive POTS, and my POTS is like everyone else's POTS, but I had a little other stuff too. I had a trigeminal neuralgia. That's not really a POTS thing, but I know other POTS patients that have it because they had a POTS like I had, that's a little confusing, but in general, I think the ME/CFS patients and researchers would say the same thing. Like post-COVID POTS is really no different than post-influenza POTS or mono POTS, post-Lyme POTS. We see all of these different infections trigger this. And I don't say that to minimize anybody. Like, I just think we need to understand collectively that these are bigger than any one viral trigger.
So while there are no biomarker for POTS, what specific larger scale research projects do you feel are lacking in the field currently? And where do you see the future of this field headed for better treatment? And that kind of piggybacks off of somebody else's question about lack of access to doctors skilled with this and treatment.
Yeah, so I would back up and I'd say there actually are biomarkers in POTS. The plasma catecholamines we talked about, I guess what that person probably means, there's no blood test that diagnoses POTS right now. Isn't like you can get a blood draw and they're going to say, oh, you have POTS. We are aiming towards that with research, but there are a lot of distinct biomarkers in POTS that are helpful in understanding the pathology. A lot of them are just done in research for research purposes because it doesn't necessarily change the treatment approach to the patient right now, but based on what we know. But so there are biomarkers in POTS. Can you give me, what was the second part of the question? Where's the research headed?
Just the difficulty in getting into treatment facilities.
Yeah. So yeah, this was a problem before COVID, our existing dysautonomia, and it's not just POTS, right? All the dysautonomia patients have this problem. There are not enough centers that do this. There are only 5 centers in the entire country that train autonomic doctors. And there was only 4 as of like 2 years ago. So adding one more at Vanderbilt has been great. There's only 8 full autonomic labs in the whole country that have that all the fancy autonomic testing. And they all either are closed to new patients or have very, very long wait lists. And it's just a huge source of frustration for our patient community. The best thing I can recommend is talking to other patients in your area. So Dysautonomia International has state level support groups. I know that Karen's organization is starting state level support groups. I know the MECFS groups have state level groups as well. Talk to patients in your communities and say, who are the good doctors around here for this? Because bouncing around from one doctor to the next is like so stressful and time consuming and expensive. And not everyone has the ability to do that.
So work and disability. Can you talk about the waxing and waning of symptoms that POTS patients experience, and what has been your experience on fighting for the disability on that front?
Yeah, so I could have added more slides on this. So myself and Kate Bourne and the University of Calgary and Vanderbilt group, we just put out a paper pretty recently on the economic impact of POTS, and it included specific data on private and government disability claims in multiple different countries, and school educational impacts, huge number of people with POTS requiring accommodations in school, about half of POTS patients dropping out of college due to POTS symptoms. So getting disability, surprisingly, about a third of POTS patients are on government Social Security disability in the US, which is a huge number of people. And they had a fairly high rate of disability approval. So about 65% that applied were approved. And that's probably using the full appeal process. I do recommend to people to please try to use an attorney if you can. Talk to fellow patients and see who are the attorneys that are good at this and that actually advocate for us and don't just try to take our money. For people who don't know, you don't have to, in the US, you don't have to pay the attorney in advance for a disability case, other than maybe some photocopy expenses and postage and stuff like that. They only get paid if they win your disability claim with the Social Security Administration. So it's worth it to try to find a lawyer. And I think that when you apply, you don't just apply based on POTS or long COVID, you sort of list everything that you have going on and really work with an attorney to create a story. But yeah, it's really frustrating for patients who can't work. And then sometimes that means you lost your insurance access and now you can't get good medical care. And it kind of becomes this cycle that's hard to get out of.
Last question. Suggestions if you are unable to have the appropriate testing done for a diagnosis.
So I think that any doctor can discuss this with you and do blood pressure measurements. I guess there are some people who don't have access to any doctors at all. I would be very worried about self-diagnosing and treating, and I don't mean that in any kind of condescending way, because all of us as patients, we sort of do figure things out on our own these days, but especially because COVID can cause complications that look like dysautonomia, I really, really wouldn't want to pursue dysautonomia treatment until you knew you didn't have those other things. So at least, call a local medical center and ask if you can talk to someone. I mean, I know that's not super helpful advice because they might not be willing to help, but hopefully there are some, you can get charitable relief care sometimes if you have real economic, if you can show an economic need, some hospitals will give you discounted or free medical care.
That wraps up our questions.
Karen,
awesome.
I have questions for you.
Oh, okay.
just one or two, because
sure.
I think you're such a wealth of knowledge, and you have impressed me. We met last year when you started doing this advocacy work, and I love that you have just rounded up the troops, and I just want to thank you for that. But also wanted to give you a chance if you wanted to share anything to encourage long COVID patients to get involved with your group too.
Absolutely. So we just launched all of our state advocacy groups right now. Earlier in the chat feature, we put the link to find your state group, and we are building state advocacy teams so that we can hit the ground running in our states. I feel like the best way to help yourself and your neighbor is to start right where you live. A lot of the work that's going on is going on with research and at the federal level, and to be honest, research takes years, and there's some things that we can start doing now to advocate for ourselves at the state level. Even things like trying to get help for disability, workman's comp, some type of benefits, medical coverage, and just raising basic awareness. So I encourage everyone who is on here to try and join your state group, try and sign up for the advocacy team. We're all sick, so I'm only asking you to give what you're able to give. We get that. Again, like Lauren said, join the state level groups for Dysautonomia International. We also have a COVID competent providers list. So similar to what Lauren was saying before, ask around, see who the good doctors in your area are, see who's willing to dive in and figure things out. So we ask that if you found a doctor that is COVID competent and is helping you, to add them to the list so that others in your area can find and access them. And other than that, we just highly encourage everybody to participate and share all the research opportunities that are going on, because without the research, we are not going to get answers. So whatever research that pops up, I know myself and a lot of the other long haul groups post research almost daily. Please read through them, check them out. Not all of them require you to live locally. Some of them are just surveys. Some of them do require you to go in person. So participate in everything that you can. It is a way to help yourself and others hopefully reach the road to recovery.
Yeah. I to close this out, I just want to leave everybody with a message of hope, because I do think the interest in COVID from the government is far more than any interest we've ever seen for all these other conditions combined. Really, honestly, like getting $1 billion in the first push for research funding is incredible. NIH's entire budget is $40 billion. So you just got 1/40th of a giant budget going to long COVID. And I am really hopeful for long COVID patients that we are going to find answers on how to help you feel better faster than many other conditions that have been around before. And that knowledge is going to help people with those other post-viral syndromes as well. So hang in there and keep up the good work on the advocacy.
Thank you. You too.
That's great. Okay. Thank you, Lauren and Karen, for everything. It was a wonderful presentation today. And thank you all for joining us today too. I just want to remind you again that this webinar was recorded and will be posted on the Long COVID Alliance webpage along with Lauren's slide deck. And you can learn more about the Long COVID Alliance at www.longcovidalliance.org. So thanks, everyone, and have a great day.
Thank you. Good night.